what we'll do is we'll start off just as an outline of the talk, and the way I've done it, or tried to do it, is really the sort of medications that you already use. Many of you probably will be using now. Most of you should be on. Then there's medications that some of you will have used, particularly if you've got more severe or unusual lupus, and new medications for the future with that caveat of maybe, because of funding. And you'd be surprised, although there's a huge amount of research, some of the more promising medications, disappointingly, don't really seem to suggest any improvement in the lupus itself. So there's many aspects to the talk, and we'll go slowly, and any questions you have, let me know. Now, this is the diagram of what lupus is about, really, and it shows you the complexity. We're not just talking about two cell types here. These are all immune cells, and the interactions between the immune cells are very complex. So I make no apologies for putting this on. This is a bit of high science, but it tells you the difficulties of trying to gauge what aspect of lupus we'll try and control. So just to sort of fill you into the causation of lupus, you've got triggers here, and the sort of triggers some of you will be things like sunlight. Some of you will get worse with things like stress. There are other triggers, medications sometimes can trigger lupus. And there are a few other triggers of viral infection. So infection is quite a common trigger of lupus. And all of these triggers then interact with the immune system. And this bit of the immune system is what, through evolution, has been preserved in many species. And this is a more specific type of immune system which targets specific viruses, bacteria, fungi. And these two bits of the immune system interact. And unfortunately, with lupus, it's not just one molecule that's gone wrong. In different patients, different aspects of the immune system are not quite working properly. And really what we're looking at is not only cells which interact, which go wrong in lupus, both on this side of the immune system and this side, but we're also talking about chemicals which are released, also which can be slightly wrong, not working properly, or going to the wrong target. And so you can see it's not just a question of developing a drug to target this cell, or this cell, or this cell, or this cell. That doesn't cure lupus, it doesn't get rid of lupus, because many people have subtly different abnormalities in the immune system, and so one drug doesn't necessarily cure everybody. It's a very wide-ranging and heterogeneous disease. It doesn't just rely on one abnormality. There are multiple abnormalities, and added into that, you've got problems with genetic issues that are passed down from family to family, which also interact with these abnormalities to make it a very difficult condition to control. And so you're all wondering, well, why haven't we found a cure? It's because it's such a wide-ranging condition, lupus. It's not just one abnormality, it's several. And different people have different abnormalities in the immune system. So, yeah. Oh, sure. I don't know if the lady can... yeah, thank you. Is that a bit better?
Can you go back to the other one?
Sure.
Yeah, can you see the other one now?
Can I just ask that please don't social media these images because they're copyright. Okay? By all means take a picture for yourself. Okay, but they shouldn't be on social media. Okay, don't share them because they're copyrighted images. And I'll be in trouble. Even though I wrote the article. So, so you can see the complexity of lupus, and the other issue is, well, which bit do we target then? And you can see, again, a complex diagram, and it's not meant to be simple because lupus is not simple. And there are multiple aspects that are being targeted, that are being looked at. And if you look at the cells, like people, cells communicate, okay? They just don't talk, well, I don't think so anyway, but they just communicate by chemicals and chemical messengers and molecules on the surface of the cells. And these molecules on the surface of the cells interact, and the chemicals which are released also interact with all of these. And so you can see from that that there are wide-ranging changes in both individuals and lupus in general, which could be targeted with a view to try and suppressing the lupus disease activity. And all of these areas have been targeted at one point or another over the last 20-25 years to try and get lupus under better control, with varying degrees of success. And as I say, it's very simple saying, oh, well, that's wrong in some, this chemical is wrong in some lupus patients, but targeting that doesn't always have the expected effect of attenuating or getting rid of the lupus for a lot of patients. And so there are many, many subtleties to lupus which we haven't yet overcome. So that's some of the difficulties that there are in lupus and in trying to control lupus. Complex and different abnormalities in different people with overlapping problems, including genetics, family history, environmental issues like stress, sunlight, viral infections, and you can then see it's not that easy to try and find an answer as to what is the best drug. Now, most of you will be on one or other of these medications. Hydroxychloroquine, who's on hydroxychloroquine? It should be pretty much everybody unless you have a problem. Do you have any idea why we put you on hydroxychloroquine? Did your doctor ever explain it to you? Anybody?
It's the first line of medication.
First line of medication, but why? Why did we give it to you? It's an immune drug. Okay? So basically it suppresses your immune system slightly. And it's been used for over 60 years. So it was hydroxychloroquine was first used in the 1950s, I think, when people with rheumatoid arthritis and malaria were given anti-malarials like hydroxychloroquine and chloroquine, and they found that the rheumatoid arthritis got better. And so since then it's been used in many conditions to do with the immune system, including Sjogren's syndrome, lupus, rheumatoid arthritis. It's a mild immune suppressant which works in many, many different subtle aspects of the immune system.
Also, my nephrologist said that the hydroxychloroquine used in conjunction with marketing is supposed to reduce the incidence of flares.
Okay, that's very good. So yeah, that's one really good reason for using hydroxychloroquine. It reduces the incidence of flares, and that's well established. So why are flares important in lupus? Well, firstly, you feel rotten. And secondly, that can cause damage. And thirdly, a flare often requires you to actually increase the dose of steroids. Many of you will be on steroids, and they are probably the worst drug for you in the long term because they cause damage themselves. Okay, so hydroxychloroquine is a very, very central drug to lupus, and all of you should be on it unless there are side effects. If there's side effects, well, nothing we can do except maybe try one of the other anti-malarials. And mepiprin is another one. Is anybody on mepiprin? Nobody at the moment. Okay. So I use mepiprin here at St George's for those patients who don't tolerate hydroxychloroquine. The evidence behind mepiprin and chloroquine is not so good as it is with hydroxychloroquine. But if you don't tolerate hydroxychloroquine, we then put you on mepiprin. We don't tend to use chloroquine so much. I don't use anybody on chloroquine here, because there's a high incidence of problems with the eyes, and much higher incidence of problems with the eyes than hydroxychloroquine. So hydroxychloroquine reduces the frequency of flares. That's an important consideration.
When using hydroxychloroquine, should it be sort of the lowest dose when you're not flaring, or can it stay at the sort of the maximum dose?
Yeah, one of the problems with chloroquine and hydroxychloroquine particularly is eye toxicity.
Yeah.
So the way I use it here at St George's and at London Lupus Centre is I start it twice a day, and then we would then reduce it down to once a day, maybe about 3 to 6 months later. And that minimises the risk of any problems with the eyes.
Okay. There's not benefit of having it twice a day long term?
Depends. If you reduce the dose and you don't feel quite so well, then clearly the twice a day dosing might be a better option. So it has to be tailored, and the important thing is to get the best effect without having any toxic side effects. And the main toxic side effect is the eyes. And we normally recommend that you have eye checks done yearly, and that's just to look for any pigment at the back of the eye. So your a high street optician should be told that you're on this drug, and they will know what to look out for. They'll do high resolution images of the back of the eye. If there's any cause for concern, which you might notice with a bit of blurring in the vision, for example, then they'll refer you to an eye doctor, for further testing, for really high sort of definition testing at the back of the eye. So methotrexate doesn't cause eye problems, but it's very expensive, and as a result, a lot of the units throughout the UK probably won't use it nearly so much. So a 2 or 3 month course of methotrexate is going to be about £700 or £800. So it's expensive, and the evidence behind it isn't so great. And whilst chloroquine and hydroxychloroquine are safe in pregnancy, particularly hydroxychloroquine, methotrexate we don't know. We don't know if it's safe or not. It probably is, but we don't take the risk because nobody's really looked. And not many people use methotrexate. As I say, we use it here and at London Bridge, but it's not widely used. So we don't know the risks in pregnancy, and that's a big deal for lupus, when most patients are going to be about 25, 30, wanting to have children. So if you're coming up to pregnancy, hydroxychloroquine is probably the most safe drug for you, and you should continue it through pregnancy. Reduces the flare rate, but there is another aspect to it, which is that studies have clearly shown that if you're on hydroxychloroquine and you have lupus, compared to patients who are not taking hydroxychloroquine, the patients that are taking hydroxychloroquine tend to live longer. Okay, and that's a really big deal because patients with lupus have premature heart disease in a group, i.e. young females, that shouldn't get this problem. But they do because of the immune problems and the inflammation problems due to lupus. So hydroxychloroquine may well actually prolong lifespan in lupus. So it's a really, really important drug. So unless you have side effects or intolerance to the drug, which does happen of course, then you should be on hydroxychloroquine, and you should remain on it through pregnancy, and it's safe in breastfeeding as well. Chloroquine and methotrexate, as I say, not widely used. In the last sort of 2 or 3 years, I've just seen one patient on chloroquine because they couldn't tolerate hydroxychloroquine or methotrexate. These are anti-malarial drugs, simple to use, good evidence, certainly with the hydroxychloroquine, helps prolong lifespan and helps reduce flare rate. So hydroxychloroquine also helps other aspects, and it's quite useful for things like fatigue. There's good evidence, certainly in pregnancy, if you stop hydroxychloroquine, women going through pregnancy feel a lot worse with their fatigue. And it also helps things like joint pains. How many of you have joint pains? So it's a fair proportion, maybe 50%. And you know, hydroxychloroquine can significantly help joint pains with lupus particularly. And this is what I've put down here. Significant benefits with mortality improvement, reduced flare rate, and as a result of that, a reduction in damage that occurs. And this is a very important concept with lupus, that when you have a flare, particularly in areas like the kidneys, the joints, this might be causing damage, which over many, many years cumulatively increases the level of damage that patients have and makes them feel worse and worse and worse. And nowadays the trend will be to try and minimise that damage by starting drugs like hydroxychloroquine early. So So once we've got through the antimalarials, for the reasons that I've indicated, the other good thing with hydroxychloroquine, by the way, is that you don't need blood testing for it, and that's a big advantage. But unfortunately, with these blood tests, and there's another one called cyclosporine, which I should have put down here, but cyclosporine, all of these tests, all of these drugs require blood testing. And they need blood testing because they can have other side effects, particularly with the liver tests and the blood count. So how many of you are on one of these drugs? So, okay, fine. And so a lot of you will be on a drug called azathioprine, which works on some of the immune cells called lymphocytes. And azathioprine has been used for the best part of 45 years in lupus. And there's very good evidence from studies in the 1970s that azathioprine is associated with, like hydroxychloroquine, with reduced flare rate. And in those days, in the 70s, if you read some of the papers, you know, they used to stop drugs to see what would happen. A bit unethical now, of course, but what happened was that patients who stopped azathioprine flared up massively. And as a result, in the 1970s, it was realised that azathioprine is a very useful drug in lupus. So, good evidence that azathioprine reduces flares and helps the kidneys. How many of you are on azathioprine? So not that many, actually. How many of you have been on azathioprine? Okay. What did you find with it? Still had a flare?
Didn't last long.
Didn't last long, right?
Serious side effect.
Okay.
Yeah.
And Rupert?
Just reduced a bit of flares for me. I didn't have it as much last year when I was on Azathioprine.
You're still on it?
I'm not on it.
You're not on it anymore. Okay. So, one of the big problems with many of these medications is the side effect profile. And many patients have one or other side effect, which means that they can be quite uncomfortable and difficult to take. Anybody on mycophenolate? So, anybody who's taken mycophenolate in the past? So, yeah, probably about 50%. Mycophenolate is often used if you have more aggressive lupus, particularly kidney lupus. And we often use it first line for those patients who have quite aggressive kidney lupus, because it seems to work quite well on the kidneys. It can help other aspects of lupus, the skin, for example. It doesn't tend to be so great for the joints, but again, some people respond differently to it. So particularly with more aggressive lupus, we try and start mycophenolate fairly promptly. And we try and increase the dose quite quickly. And of course, all the while, patients are having blood monitoring and are being tested for things like liver and blood counts. So you'll notice that anybody who's on it will have blood tests every 6 to 8 weeks when they're on it. Methotrexate, anybody on methotrexate? So a couple of you, or 3 or 4 of you. How have you found it? It helps.
I mean, I was on tablet form for a couple of months, and I've always felt nauseous.
Nauseous, yeah.
And now I'm on the injection, which is actually a lot better. I don't get many of the side effects, and I don't have to take more pills in order to beat those side effects either. So it's actually helping. I would say the injection's better than the pill.
Better than the pill, yeah. And a lot of people find that one of the advantages of methotrexate, unlike all the others, is that it can be taken by injection. And nausea is quite common with methotrexate. And in my experience, it probably occurs in about 20–25% of patients, which is quite high. Only in a few of those patients does it need to be stopped, but it can be a reason for stopping the drug because nausea just becomes too much. For those of you on it, if you want, you can actually split the dose morning and evening, or one morning and the following morning, and sometimes that helps the nausea. And the other thing is you need to take a drug called folic acid either the day after or the day before, and the amount of folic acid can be increased to 4 or 5, sometimes 6 times a week which sometimes can help attenuate some of the nausea that occurs with methotrexate. Yeah?
Are they in any particular order?
No. Is there a reason that you asked?
Because I was trying to figure out, would you give someone azathioprine first and then go on?
I mean, that's a good question. So the type of lupus sometimes does dictate what we do. So if some of you have quite predominant joint pains, and remember some of you will have overlaps with other conditions like rheumatoid arthritis or Hotung syndrome, quite often we would start with something like methotrexate. And the reason we do that is because methotrexate, we've transplanted a lot of information from rheumatoid arthritis. Now, rheumatoid arthritis is probably the best studied immune condition. And there's been some wonderful, really, really high quality research over the last 15 years that has really defined what works and what doesn't work very well with rheumatoid arthritis. And methotrexate works very well. It is pretty much the gold standard drug for rheumatoid arthritis still. And we've then transplanted that data to other conditions like lupus and used methotrexate for those patients who have predominant joint pain involvement or an overlap with rheumatoid or Hotung syndrome. Some people have an overlap with psoriatic arthritis. I don't know, how many of you had psoriasis? Anybody here? Nobody. But if you've got an overlap with other conditions, that where we know methotrexate can be helpful, we then would use methotrexate. In general, if you've got problems with fevers, sweats, even some joint pains, chest pains, a general kind of lupus flare, which is persistent, then azathioprine would be a good drug. And mycophenolate and azathioprine work in a similar fashion, but mycophenolate is just more expensive. So we generally would start with azathioprine, and if necessary, we'd change to mycophenolate, particularly if you had involvement in the kidneys. Azathioprine can work for the kidneys, but not in the early phase, and it's usually later on that you might be on azathioprine for the kidneys. But mycophenolate is still the preferred option for the kidneys in general. So the type of lupus can be important. We find methotrexate is quite useful for skin lupus as well. We use it a lot in combination with mycophenolate. So some people are on mycophenolate for the kidneys, but it doesn't help the skin. And we do find that fairly frequently. So we don't have to add in other drugs. And we find the combination of methotrexate and mycophenolate can be helpful for that.
Do any of these agents start particularly well for problems with lungs opposed to lupus?
Yeah, well, the lung problems related to lupus are usually things like, well, probably the commonest one is something called serositis. That means inflammation in the lining of the lung. The lung is made up of air space, as you all know, and outside it's got a little barrier, a lining. And there's two bits of the lining there, one attached to the lung and one attached to the chest wall, and they slide over each other as you breathe in and out. Serositis is when fluid develops in that space, and you get chest pains. Okay. And serositis is quite common. And we use, for things like that, we use anti-inflammatories, we use steroids, and then if it's a persistent problem, we would put you on one of these drugs, usually something like azathioprine.
I've got lung involvement. I'm not mycophenolate for that. I've also had chemotherapy for lung involvement.
The lung. So some people, remember, have more aggressive lung involvement, so they might have fibrous tissue in the lung. And if you've got fibrous tissue in the lung, it's an unusual manifestation for pure lupus, but it can happen. Then using something like mycophenolate, and there's another drug called cyclophosphamide, tend to be the drugs that we would give for more severe lung involvement. Okay. And there's some evidence that mycophenolate can help, some evidence that azathioprine can also help, but generally my preferred drug is mycophenolate for that. So again, just gives you an idea that the different types of lupus are managed slightly differently depending on what the pattern of involvement is. Leflunomide is used less often, and leflunomide just reminds me that one of the issues with many of these drugs, again, is pregnancy. And whereas I've said hydroxychloroquine is safe in pregnancy and it should be carried on throughout pregnancy, some of these drugs are not safe in pregnancy. So mycophenolate, methotrexate and leflunomide are not safe. So if you're on them and you wish to become pregnant, you have to stop them. And mycophenolate and methotrexate can be stopped 3 months beforehand in consultation with your lupus physician, of course. Leflunomide requires a little bit more of a convoluted withdrawal, stopping the drug and then having what's called a washout with another drug called cholestyramine, which literally sucks the leflunomide out into the bowel, so you pass it out. It's a convoluted issue with leflunomide. So it's not the best drug if you're young and female, because if you want to become pregnant, it becomes much more difficult to stop. And then levels have to be monitored of leflunomide. There's one in here called cyclosporine, which is again safe in pregnancy. And cyclosporine, I don't know, anybody on cyclosporine here? You've been on it. Okay. And cyclosporine can sometimes be used, and we sometimes use it specifically because it is thought to be safe in pregnancy. It's compatible with pregnancy, as is azathioprine. But the other ones are not, and so that becomes quite a tricky issue at the time of wanting to conceive. The general advice, however, is the same, in that get your lupus under control first before you conceive, before you have children. If the lupus is not under control and you become pregnant, then there's a much higher risk that the pregnancy will not end well. You'll flare up, it'll be much more difficult to control. So that's the general advice. Make sure you're monitored carefully at the time of conception. Make sure you're off drugs that you shouldn't be on, and make sure you're on drugs that you should be on, like hydroxychloroquine. Some people need steroids, some people need azathioprine, not everybody, but in general that changing of medications prior to pregnancy is vital, and you've got to liaise with your physician, with your lupus specialist at that time. Any questions at all? So methotrexate is quite a good drug for lupus, and we know that it can be quite helpful. I've found it helpful again in combination with mycophenolate, and there's some patients who have kidney lupus where we've added methotrexate in, and actually the kidney lupus has also got better, particularly with mycophenolate on board. And so it's quite a useful drug, but not safe in pregnancy. And whilst some of this data suggests that the amount of steroids that patient needs, for example, reduces, as with azathioprine, methotrexate has the disadvantage that it needs blood test monitoring and it's not safe in pregnancy. But overall, a good drug that you can have added in at any point. So I've just put this up for those of you who have joint pains as a sort of an algorithm of the sort of things that we use. And in some ways, the complexity of it really just tells you how difficult it is to treat things like lupus joints and other aspects of lupus. And the number of medications here, again, tells you that I've always been told if you've got several medications that might help, it's likely that none of them work. There's not going to be one medication that really takes joint pains away. It's going to be likely to be several strategies, several medications, and that's why many of you will be on more than one medication. It's because one is not quite addressing the issue, or is addressing some issues but not others, and then therefore we then have to add in other medications like methotrexate, like mycophenolate, to try and control the condition. And this just harks back to that original diagram I had, where you can see the complex interaction between multiple cells. And some of you may have some interactions which are not quite working to cause the lupus. Others will have other interactions which aren't working. And different drugs address these interactions at different points. And so you can see from that you might need different drugs to other patients.
So you've got NSA ideas.
Yeah.
This week there was a big article I think in London or a news study that said if you take NSA over a long period of time, it really impacts heart conditions.
Yeah.
So I'm wondering, bearing in mind what you just said about us having predisposition to heart conditions, what should we be doing?
Well, I think firstly, data like this comes out all the time.
Right.
And we know that NSAIDs, and for all of you that may not be sure what that means, that just means non-steroidal anti-inflammatory drugs. Things like ibuprofen, which you can buy over the counter, and the drugs which you will be prescribed, so things like naproxen, diclofenac, celecoxib, alcoxia. These are all anti-inflammatory drugs. They work in a certain way. They have well-known side effects, and one of those side effects, which came out about 10, 11 years ago, was there may be a slightly higher risk of heart disease with long-term usage over 18 to 24 months of using NSAIDs continuously. And of course, there was a drug called Vioxx at that time, which was wonderful, and many patients really thought Vioxx was a brilliant drug. My pain's much better, which was withdrawn from the market because in the States people started suing because they had heart attacks. It's a shame, obviously, that the data suggested there was a link, and the latest study suggests that about 19% of patients who take these drugs end up in A&E from heart failure. Now, my view on it is that you must minimise your dose of any drug compatible with toxicity. Okay? So, hydroxychloroquine would be a core drug that I would say continue long term. If you're very well, then there are few other drugs I would say you've got to take it, you've got to take it, you've got to take it. Okay? If your condition is very stable and there's no other organ damage. NSAIDs can be very useful for those of you who have joint pains, for example, or don't feel well from the serositis, the inflammation causing chest pain. And taking it irregularly from time to time, I don't think there's any evidence that really will impact on it. The problem arises if you take it all the time. And even then, you know, we have patients with other conditions who rely on these drugs to get them through the day. They're not in A&E every single day. So my own feeling is, I haven't read through the data in detail, is take it with a pinch of salt. The media tend to sensationalise this data without reading the meaning of the data. Okay? And I can tell you now that NSAIDs, I don't see 20% of my patients on these drugs attending A&E every 6 weeks. It doesn't happen. So take it with a pinch of salt. Remember, medication is there for a purpose, to try and help your symptoms. And if you're taking it to help your symptoms, and it helps, take it for the time it helps and then stop it. The NSAIDs would come into that category. You don't need to take them every day forever. If you do, then your doctor needs to change your treatment around so you're not taking the NSAIDs so frequently. Okay. So take it as you need it. The data we know about, and this new data is not necessarily telling us anything about the lupus population at all. And I'd need to read the study, but you know, I'd be surprised if it actually bears out into real-world practice. So take it as you need it, okay? And don't worry, because you've got to remember every drug has a side effect. So what do? Do you live your life in pain and say that's got a side effect, therefore I'm not going to take it? Not really. Okay. So long as the side effects are predictable, we know about them, then anybody at risk, and that includes people who already have pre-existing heart failure, shouldn't really be on NSAIDs, and that's what we say. Okay? So in the lupus population, I think it's unlikely to be a significant factor, okay, unless you're taking them every day for years and years and years. And there are not many lupus patients that do that. I don't know how many of you take NSAIDs every day for years and years and years.
What comes under NSAIDs?
So ibuprofen, naproxen, diclofenac, naproxen. Anybody else? I don't think anybody really takes them in that way. Okay, and they have other side effects, including problems with the stomach. They can cause indigestion. My advice is take it as you need it. Okay, you've got to remember there's a little bit of confounding with some of these studies, and that means the inflammatory process generally, like lupus, will cause accelerated heart disease. And part of that manifestation are things like joint pains. And if you get rid of some of the joint pains by using an anti-inflammatory, you might actually be reducing some of the risk of the heart disease in the first place. So leaving a condition untreated might actually be a little bit more worse for your heart than treating it. Okay, so there's that other aspect here. So take it with a pinch of salt. I've yet to read the study, but I wouldn't be surprised if it says nothing of the kind. And it's probably looking at 70-year-olds who've already got heart failure, in which case, of course.
It was 77 was the mean age.
Is that what it was?
Yeah, it was 77-year-old.
For heaven's sake. Yeah, heaven's sake.
No, but I guess what it is saying, and
Yeah.
you're just saying exactly the same. If you take something like that over a long, long period of time, every single day,
Yeah.
then your risk factor obviously up.
Yes, but it's not an absolute. I think it's really, really important to remember there are going to be some patients who are at risk. So if you've already got heart failure, or you've had heart disease, I would not say take anti-inflammatories every day, okay? But, on the other hand, if you're 25, 35, 40, and you've got lupus, you're in pain, take it intermittently. If you're still getting joint pains, we need to address it some other way rather than NSAIDs or steroids. Those are the two no-nos, I would say, long-term, okay? But you will still find patients with other conditions like rheumatoid, psoriatic arthritis, and even lupus who are on them every day because they need them. Now, in those patients, we have to be pragmatic and just say, let's try and address all your cardiovascular risk factors. Yes, there may be an issue with long-term usage, but it doesn't apply to absolutely everyone at all. And there's some patients who will actually be reducing their risk of heart disease because they're controlling their symptoms, and therefore they're controlling the disease activity a little better with the anti-inflammatories. Okay? So it's not a black and white scenario. If you've got pre-existing heart disease or have had a heart attack, I wouldn't put you on long-term NSAIDs. Okay? But anybody else, if they need the drug, they have to be on the drug. It's as simple as that until we get better control of the condition. And I would put data like this aside and just take it with a pinch of salt. Sorry, yeah.
If you have a secondary condition, like for me, ITP, then we're not allowed NSAIDs.
Correct, yes. Yeah, there may be pre-existing conditions that it's a little bit more difficult to take the NSAIDs. It's not an absolute, so if your platelet count is over 100, for example, you may be okay from time to time, but it wouldn't be something that we would recommend unless you really need it. So I think there was another question.
Oh, no, it was just about the mean age of subjects in that study being quite high.
Quite high, yeah, exactly. And I think these kind of studies are grabbed by the media and presented as an absolute that applies to absolutely everybody. It doesn't, okay? And these studies really do have to be interpreted with caution. It's great for the people who do the study because they get on TV, okay? But for the rest of us, we're left with questions like this, legitimate questions, so don't get me wrong. These are really, really important questions, okay? But they don't necessarily apply to you. And the study wasn't really looking at lupus. So in my view, take what you need to get better, to get through your day, okay? Try to minimise your medication burden, and that includes the NSAIDs. So we come on to some of the newer drugs that some of you might have been on. And has anybody heard of Rituxan here? Has anybody used Rituxan? Okay. Legally, I hope, not through, not through the internet. I don't know if Amazon does it or not, but so Rituximab is one of the newer drugs. And I say newer, many of these drugs have gone through a process of clinical trials and studies and have been around really for the best part of 15 to 20 years. So Rituximab is not that new a drug. It originally was used in the treatment of cancer. So lymphoma is where it was used. And you'll find in your internet trawls that some of these drugs, and this frightens people, okay? That's why I'm addressing the issue here. It frightens people that this is used in cancer and that methotrexate is used in cancer. And I get many patients saying, I don't want to be on this drug because it's used for cancer. Now, the reason we get these drugs from the world of cancer is quite simple. Cancer has got a lot of money involved in it, and it can develop these drugs, which is fantastic for the rest of us who don't have quite so much money. Okay, you'll know from your own experience, the TV adverts for Macmillan nurses, for cancer research, let's beat cancer. they will raise many, 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 many hundreds of millions of pounds. And that's brilliant because it allows cancer researchers to have the funding to try and help patients with cancer. Rituximab was one of these drugs, and it works in a particular cell called the B cell, which is very important. I don't know if I've got an actually, here we go. Which is very important in lupus. Now, 15 years ago, people thought that, is the B cell that important? It just produces antibodies. Antibodies are these proteins that attach to bacteria and try and kill them. Is it really that important? Is it really that important? They used rituximab in rheumatoid arthritis and found wonderful results, really, really good results. And so then it was used in lupus. Same effect, it attaches to something called the B cell and then stops that B cell functioning and gets rid of it, certain types of B cell from the system. So the counts of the B cell actually in the system in your bloodstream will then drop quite often to 0. And you might then think, well, doesn't that leave you open to infection? If you haven't got these cells producing these antibodies which protect you, would that leave you open to infection? Of course, these are issues that we have to confront as well, and we'll come on to that in a second. But this was the real reason why it was used, and it gravitated down from the world of cancer for that reason, that it worked in certain type of cell types which we thought were probably going to be important in lupus as well. Now, rituximab has had a checkered history because initially 10, 12, 15 years ago, people started using it in lupus and for general lupus as well as for kidney lupus, and found, well, actually, this is really good. It works. And then there were 2 really, really big studies done about 8, 9 years ago. One called LUNAR, L-U-N-A-R, and one called Explorer. And those studies look specifically at how good this is in a multi-centre study. So in other words, not just one centre like St George's saying, oh, it works, but utilising this drug over many centres globally, in the States, in Europe, and in the Far East. And lo and behold, what the studies found is actually doesn't seem to do very much, which is a really disappointing result. And then there were recriminations, why has that happened? You know, is it the study design? Is it the design of the study? In other words, patients with who were taking placebo instead of the rituximab were allowed to change their steroid dose, for example. Could that have reduced the difference between the groups who are using rituximab and the other groups which are allowed to use, for example, steroids for any flares? And it was then found that actually that's probably likely to be the case. Those studies were not, because we can't prevent patients with flare-ups from being treated, that's unethical. Those patients also who were given placebo had normal standard treatment, and it may have been that that normal standard treatment allowed their lupus to improve as much as the rituximab. And so the difference couldn't be found. And so there were many aspects to that study which made it difficult to actually find a difference between the 2 groups. And for that reason, everybody was despondent. We thought, well, we finally have a new drug, very much like rheumatoid arthritis has several new drugs. And if you look at the world of rheumatoid arthritis, it's magnificent. It's got loads of new drugs all the time, churning out different mechanisms of action, all working very, very effectively. With lupus, it's not the same. It's too complex. And as I alluded to in that original diagram, that's the reason I put it up, it's not simple. And so no difference was found. Everybody despondent, everything on, let's go back to the drawing board. But more recently, we begin to challenge that assumption that rituximab doesn't work. And we think it does work, certainly in certain aspects of lupus. There's a study which maybe some of you are part of, called the Rituxan study, which is being carried out at the Hammersmith Hospital by a kidney doctor called Liz Lightstone. They've used rituximab and found it to be quite helpful for kidney lupus over many, many weeks. And what this graph shows is patients who either had complete remission from their lupus, so quite a high proportion. So this is the proportion of patients who reach this target, complete remission. It's quite high. And it's at odds with the original Explorer and Luna studies. And so this is an ongoing study. And there's another important aspect to this. How many of you are on steroids? So really, you're probably, again, about 50%. How many of you have been on steroids? So we're probably talking about 3/4 of the group, really, have been on steroids at some point. What's the problem with steroids? Well, steroids cause 101 side effects. They're quite dirty drugs. And people worry about methotrexate, but actually steroids are far, far worse in their side effects than methotrexate. And steroids cause problems such as weight gain, they can cause diabetes, they can cause problems with the eyes, cataracts, glaucoma or high pressure in the eyes. They're very potent immune suppressors, and there's good evidence that they probably have the highest risk of infection of any of the immune suppressing drugs attached to them. They can cause thin skin, they can cause easy bruising. I could go on. Okay. So they work in a specific way, but they're bad news in terms of side effects. And there's very good evidence that much of the damage that occurs in lupus, that patients who from the 1960s, 70s, 80s who would have been on high-dose steroids, much of the damage that's occurred to their bodies is actually not as a result of the lupus, but as a result of the steroids. Okay? So one of the attractive propositions that was put forward with this ongoing study is, could we actually prevent the use of, or the overuse of steroids? So all that was done here was patients were given steroids when they were given the rituximab, but no other steroids at all. So they weren't given steroids afterwards. And that's quite hairy for somebody who's got kidney lupus, because we don't want any chances taken with the kidney. If you lose kidney function, you don't get it back. And so this is quite an attractive proposition, and it seems to work quite well in certain types of lupus. But actually just giving steroids by infusion at the onset, and then giving the rituximab, and then afterwards giving mycophenolate, seems to help a lot of patients with kidney lupus quite significantly. And so it goes against some of the data that Explorer and Luna, the other rituximab, the larger rituximab studies suggested. So rituximab seems to be a good drug, and we are now starting to use it again. Now, the reason we can use it, it's an expensive drug, and so it costs about £8,000 to £10,000 a year using it for patients, not cheap. The reason we can use it now is because the people who fund it, called NHS England, and we're a specialist centre for NHS England, so if we feel somebody needs rituximab, if they fulfil the criteria, then they can have it. But NHS England is willing to fund this drug for lupus patients. And it was, I think, through the hard work of people like Professor De Cruz and Professor Bruce in Manchester, really, that put forward the case for rituximab, despite the evidence not being great. And the evidence just was that people will die if they don't get rituximab, and it's as simple as that. So there are some lupus patients who have not responded, who actually won't respond to other drugs, who could end up losing their lives if rituximab hadn't been approved. It is approved now, so particularly for kidney lupus, if you need the drug, you need to be in a specialised centre, and there are 9 of them in London. So it's ours, Guy's, St Thomas's, UCL, Bart's in London, King's, they're all free. So if you need rituximab, at those centres, you will get it, despite the expense and despite the absence of really rock-solid evidence behind it. There's some people who definitely will respond very well.
Can I just ask you, with the Professor Lightstone research, is it the fact that there's a rituximab, that she's having to fight for the case for rituximab? Because I was contacted to provide a my case study on why I think it's beneficial to me.
Yeah.
So is it kind of under government threat?
The study,
No, well, even the...
or the Rituxan,
yeah, of the
No.
disseminate, because I wondered why I was contacted.
no, it's not under threat. In fact, the guidance from NHS England, who give us the money for the drug, has only been published about a year and a half ago. So it's not under threat. Okay, so rituximab will be used, and in fact, the number of indications for using rituximab will widen as time goes by. So it might be useful for things like scleroderma, and it might be used for things like lung disease in the future. Okay.
So if you're not from London,
Yeah.
can't get, it wouldn't be available to you?
No, it can. So I'm just talking about the London-wide centres. So what technically needs to happen if a lupus patient needs rituximab is, even if they're not in one of these dedicated specialist centres, so if they're not here, for example, at St George's, the local physician who thinks you need rituximab at your local hospital should then contact the lead lupus physician at the trust which is approved, like here, and say, this patient needs rituximab, can you authorise that? Okay. So no patient should go without the drug that they need, i.e. rituximab. It just needs a bit of a process between the physician who's looking after you locally, if that's an outside hospital, and the hospital that is the designated specialist centre to provide the drug. And these are nationwide, so there are hospitals in Birmingham, there are hospitals in Manchester, Newcastle, there are other specialist centres all through the country. It's not just London. London's just obviously big, there are 9 specialist centres dotted around London, and we're the dedicated specialist centre for South West London. And we have good links with our local hospitals, so you know, we're trying to set up a network of local hospitals, so hospitals like Frimley Park, for example, or St Helier, Kingston, Queen Mary's at Roehampton, Croydon. All of these hospitals will come under the network of St George's, hopefully in the next year, 18 months, where the local physicians will say, this patient needs rituximab because they've got kidney lupus or whatever, and then they'll contact me, and then I'll say, yeah, no problem, we'll give that. Patient will come here, have the rituximab, and then go back to their local hospital. Okay. And I think that's probably, I don't know what you all feel, does that sound like a reasonable system?
Well, what about the criteria? Because I remember speaking to Dr. Cruz, and he said that you'd have to meet a criteria in order to get it.
You do need to meet criteria, and those criteria are, you need to have tried cyclophosphamide, okay, first, but the problem with that is not everybody wants cyclophosphamide, so it is possible to circumvent the criteria if you don't want cyclophosphamide. And some people don't want cyclophosphamide because of the potential, and it is a potential risk of infertility with cyclophosphamide. So some women don't want to have it. Okay, and then you need to have tried and failed mycophenolate for kidney lupus. Okay, and so there are certain criteria which you need to fulfil, but really that's fine, you know, because we need to have tried the other drugs anyway first. So mycophenolate particularly is a very important drug in kidney lupus. And that's one I would put anybody on anyway. So it's not like it's asking you to do something which you don't want to do, if you see what I mean. And as I say, with the cyclophosphamide, some women don't want to have cyclophosphamide, understandably. The risk of infertility is very, very low. In fact, virtually zero. The St Thomas's experience over a long period is cyclophosphamide doesn't cause infertility at the doses that we use, given every 2 weeks for 3 months. So infertility is rare, really, really rare under those circumstances. But, you know, I'm not a woman who wants to have children. But if you are, I can understand why you might be spooked by that, by the possibility of being infertile. And that's permanent. And so sometimes we also provide the possibility of egg preservation for those women who are a little bit worried by cyclophosphamide. I haven't specifically talked about cyclophosphamide here, but it is one of the potent drugs that we use and has been used many, many years. But we try and use less and less of it nowadays because we've got mycophenolate, which seems to be as good as cyclophosphamide in kidney disease. and we've got drugs like Rituxan, and hopefully some newer drugs as well. So, sorry.
Can I just ask, if mycophenolate, I was told once that it's a low-dose chemotherapy drug, is that true?
Mycophenolate?
Yeah.
Right, so this is what I was alluding to earlier on, that people get spooked because it's a cancer drug, and it's chemotherapy. Now, I would urge you to just put all of those issues out of your mind, okay? Frankly, it doesn't matter if it's being used to play football, you know, in Swaziland or South Africa or the North Pole. It doesn't matter, okay? If it works for lupus, and if we're confident it's been approved, remember there's a regulatory process for all of this. If it's been approved, and we know the side effects, and it works in the condition, there's good evidence that it does, then whether it's used in other areas or not is not relevant, okay? I understand why you might be all spooked by this, but the world of cancer has allowed us actually to use some of these drugs, and that's a beneficial thing. It's not a bad thing.
Okay. Isn't that the case with most drugs? Most drugs have a dual function. They're not for one condition, they're generally used for other conditions as well. Anyway.
Yeah, absolutely. Just as an example, the anti-TNF alpha drugs, which are used for rheumatoid arthritis, very effective. 15, 20 years ago, they were used, very good results. And they're still widely used. The most common newer drugs, so-called now newer, now 20 years old, which are used. As soon as people realised, oh, it works for rheumatoid arthritis, started using them in 101 other areas. Okay? You can be sure it's been used in cancer. You can be sure it's been used, believe it or not, in pregnancy. And now, one of those drugs, Humira, is actually used as part of IVF. Why should that spook anyone? Okay? That's a good thing. If it has multiple areas where it can be used, and it's the same with many of these drugs, you know, multiple areas where it can be used, it doesn't matter. All it does actually is broaden our experience of the drug and tell us in many, many areas where problems can occur and where good things occur. Okay? So having that broad usage of these drugs, which includes things like mycophenolate, is actually a good thing. We then get information from the bowel doctors, from the cancer doctors, from the dermatologist. When do you use this? You know, what problems do you get? And rather than having one person using it, we then get 100 people using it with that experience. And that's actually a good thing, because it makes life for you better, because we can then tell you, inform you better as to what the problems with these drugs are and what effects you should expect. So using it as a cancer drug, please do not be worried about that. I'm not sure where this issue comes from, but whether you all feel that because it's used as a chemotherapy drug, it causes cancer. Is that where? So what's your concern? It's the toxicity.
Yeah, for me that's what it was, which is like, whoa, this is the first line decision, you know, major one of the side effects, and when you're using one drug and then you're taking another drug alongside, you've got side effects from that drug, side effects from another drug, and then the complications and all that just seems overwhelming.
You're absolutely correct. I mean, I think it's important to look at the side effects, but we also have to look at the bigger picture. And in lupus, for example, I have many patients who are 25. Okay? I want them to reach 95. Okay? And I'm willing to tell them what the side effects of many of these medications are, and for them to make an informed decision. The bottom line is it's really up to you whether you want to take the medication or not. But it's my responsibility to make sure you understand what the implications are for taking it or not taking it. It's your decision, what you do. But the important thing is that there's good evidence that this drug, with hydroxychloroquine for example, will help you live longer. It's a no-brainer for me. Okay? It's the same with mycophenolate, same with azathioprine, same with Rituxan. And if we didn't have Rituxan, for example, if you were worried it's a chemotherapy drug, which it is, then I would say to you, your options are the mycophenolate is not controlling your kidney lupus, let's say. We know from data 30, 40 years ago that the 5-year survival of somebody who had uncontrolled kidney disease, 5-year survival was probably of the order of about 5 to 10%. So that means 90% of patients will die. Okay. That was 40 years ago. That's uncontrolled kidney disease. Now we still see uncontrolled kidney disease. Don't think it's all gone away. It hasn't. Okay. So that could still apply to some of you if we don't do something about it. Now,
when it's put like that, it's a no-brainer. But we're not always given the information to make an informed decision. It's thrust upon you. This is what's wrong with you. Take this and get on with it. And then when you go home, you look at it, read the side effects in isolation by yourself without having any medical knowledge and expertise, and you just freak out and think, forget that, I'm not taking it.
But that's the purpose of these meetings.
Yeah.
Precisely the purpose of the meetings.
That was the only point I was trying to make, because I had Causation on my Rituxan and I'm on microphone, so I'm not really bothered.
Yeah.
It's just that at clinic level, you're not given the right information. I find it through other sources.
Yeah, I agree.
And that's how, after I've taken them.
I agree entirely. I think the point you made is a very good one, because this is a point that's shared by all of you. I'm sure at some point you're wondering about the medications. And it's difficult sometimes as doctors, because we prescribe these all the time. And for us, we probably don't think about it in that way. But actually, for you, it's the first time. And I can understand that, but I would urge you to dispel those notions, because remember, we're not entering you into clinical trials without letting you know. We're not using a drug we shouldn't be. Okay, these are all drugs which have been approved by the European Medicines Agency and have been tried and tested with predictable side effects and with hopefully positive results. And they just allow us to have a broader range of guns, if you like, to try and tackle the lupus with. And we're rather jealous of rheumatoid arthritis, because, as I say, newer drugs come along, they always seem to work, they're always licensed, they always get used, and we've got a huge number of drugs. Lupus isn't in that category, and it's almost like the poor relation. Because it's so complex, we've not been able to find a drug that miraculously really helps.
Did it used to be, or is it still hospital only, or on a named patient basis?
Yeah, it's not hospital only or named patient, but because it's expensive and because GPs rarely even know about it, because they don't use it that often, they almost certainly won't prescribe it for you. Now, GPs are also constrained because they have a set of drugs which their local sort of CCG, the funding body, will say, yes, you can use this, but you can't prescribe that. Okay? Methotrexate sometimes comes into that category. Okay? They'll say, I'm not going to prescribe it. Usually not, but Methotrexate certainly is one of those drugs where your GP almost certainly will not prescribe it. Are you on Methotrexate?
No, I just remember it being a few years ago, named patient only when I used to work in hospital. And it's the same thing with my mates, isn't it? That it's only what my GP will prescribe, so I take.
Again, it's variable. Some GPs will prescribe it, some will not. Okay? Local practices vary enormously, which is unfair, really, when you think about it. But local GPs will have their own set of guidelines as to what they feel comfortable prescribing and what they don't feel comfortable prescribing. Okay? And it will vary from GP practice to GP practice, I'm afraid. And from my perspective, if you can't get a drug from your GP, then we'll prescribe it here. It just makes it a pain, because you then have to come and collect a prescription, etc., etc. It's the same with blood testing. Not all GPs will do the blood testing to monitor these medications. Some will, some won't, and it varies. Okay? It's not a good system, because I can't predict who will or who won't be prescribed drugs. And I get patients from all over the country sometimes who then have to be sent prescriptions or have to collect prescriptions. Methotrexate is one of those. It's not commonly prescribed, and as I say, part of the reason is unfamiliarity. The other part of the reason is it's expensive. And it's expensive because only Boots distribute the drug in the UK. And the number of indications for Methotrexate, minimal. Lupus is pretty much it. Any other questions at all?
A lot of these drugs you mentioned, these aren't the generic names, are they?
No, so we use these are the generic names, not the trade names.
Right.
Yeah, so rituximab is the generic name, but it's called Madthera. Is the trade name. Azathioprine is Imuran usually. Sorry. Yeah.
Is there, I've seen there's another drugs quite similar to the rituximab. I think it begins with E, but I can't remember.
Eprotuzumab.
Yeah.
Yeah, the studies of that did show some benefit, but it's not being used in place of rituximab. It's not widely used. The trials of that haven't shown a good rationale for using it at this moment in time.
I have read somewhere, heard somewhere that the differences in the medication used, whether it was hydroxychloroquine, the generic name is Plaquenil.
Yeah, Plaquenil.
Yeah.
So Plaquenil is not available anymore.
Ah.
Okay, so Plaquenil is not made anymore, but for those of you who, we actually like Plaquenil because it seems to have slightly fewer side effects than some of the other drugs. So Plaquenil is not available, but it's made by a drug company called Sanofi, and under the brand name Zentiva, so Zentiva. So if Plaquenil is what you were on, you can actually have the Zentiva brand of hydroxychloroquine, which is exactly the same drug. It's just not called
I was
Plaquenil.
always told hydroxychloroquine was a better one to have than Plaquenil.
No, we find the opposite. We find Plaquenil is actually a better drug. We find slightly less side effects with it, actually. The formulation might change and things like that. Okay, so just moving on. So the term for these newer drugs that target certain areas, like rituximab, and we'll come on to another one called belimumab, they're called biologics, to distinguish them from the older drugs, which are called DMARDs, or disease-modifying anti-rheumatic drugs. There is a risk of infection with some of these drugs, but as I was alluding to on the previous slide, if you get rid of some of these immune cells, does it make you open to infection? Well, the answer is there are some infections that you need to watch out for, particularly things like soft tissue infections, respiratory tract infections, so chest infections. With rituximab in particular, there's a condition called progressive multifocal leukoencephalopathy, or PML, just call it PML, which is a viral infection which was picked up in some of the studies a few years ago. Very, very few, very rare, but it is a potential side effect of rituximab. That's caused by a virus, and it can be nasty, but it's extremely rare, thankfully. Very, very few cases. Looking at all of you, you're all here, most of you will be on immune suppressing drugs, and you're still here. Okay? So that tells you something, and that tells you that actually, practically speaking, the number of infections that we actually do see is really, really, really tiny. Okay? I can't remember the last person I had, coming in with a really severe, life-threatening infection from one of these immune suppressing drugs. Now, you might be surprised by that. You know, surely we should be seeing a lot of people coming through A&E, at death's door. It doesn't work that way. So whilst I appreciate a lot of you will be worried about the risk of infection, in the real world, actually the vast, vast majority of patients handle these drugs really well. We have to be cautious, of course, and we never take anything for granted. But the number of people having side effects is minimal. There are some other issues that, before you have these drugs, that we always screen you for. You'll be screened for things like HIV, hepatitis B, hepatitis C, before you start these newer drugs. And that's because there's some risk of reactivation. And probably the worst one is hepatitis B. And if you've been exposed to hepatitis B, there's always a risk of reactivation of hepatitis B with very potent immune suppressing drugs. It's because the hepatitis B attaches to the DNA in the liver cells and just hangs around. And so there's a risk of reactivation. So if you're having any of these biologics, normally you'd get tested. So if your physician says, you're going to have an HIV test, it doesn't mean that we think you've got HIV or you've been a naughty boy or a naughty girl. It just means that we have to be clear that you're negative before you start these drugs, because there's a risk of reactivation of some of these viral infections. So, moving on from rituximab, there are some other drugs which have been used. There's too many really to go through all of these. Tocilizumab is another drug that's been used in lupus, and it seems to be influential in certain chemicals called interleukin-6. And interleukin-6 seems to be important in promoting or driving inflammation, and it's been used in lupus with some results which seem to be beneficial. It has side effects as well, and we would use tocilizumab really, particularly if you've got joint pains which are intractable in lupus and nothing's worked, just try and settle or calm them. And again, these studies have been not done globally. These are small-scale studies, and this is one of the big problems with lupus, that actually some of these studies are so small-scale it's difficult to extrapolate from that to a more generalised cohort of lupus patients. But it just gives you an idea there are options available for particularly resistant lupus, and tocilizumab once again has been used in rheumatoid arthritis, first of all, found to have very, very good benefit in rheumatoid arthritis. Anti-TNF-alpha drugs, these are some of the drugs I spoke about earlier that have a really, really beneficial effect in rheumatoid arthritis, and they're quite widely used now. Drugs like infliximab, Humira, etanercept. Just going to move on from that. And one of the problems with anti-TNF-alpha drugs was that they're a cause of drug-induced lupus. So these drugs, used for rheumatoid arthritis, can actually cause lupus. And I've come across 2 or 3 cases actually of skin lupus that have been caused by these drugs in rheumatoid arthritis patients. So you then ask the question, what stupidity would it be to use this drug in lupus? You might think, that's daft. It causes lupus, so why would you want to use it? But of course, lupus being a really, really complicated condition, many mechanisms are involved, and people have used these drugs in lupus patients, because there are some patients who don't respond to any drug and still need other medications to see if they work. And this is a very, very small scale study, so there's only 6 lupus patients, not many, that looked at kidney disease, some with joint problems which wouldn't respond to any drugs, and the SLEDAI here is just a marker of disease activity. So just think of SLEDAI, SLEDAI, which is Systemic Lupus Erythematosus Disease Activity Index. Okay, that's what it stands for. That's just a marker of how active the lupus is. And you can see from that the activity of the lupus with these drugs actually drops. So quite the opposite of what we might expect with a drug that is known to cause drug-induced lupus, is that under certain circumstances, particularly if you have very resistant lupus, it's worth trying other avenues to see if they help. And with anti-TNF-alpha therapy, drugs like infliximab, Humira, etanercept, and there are a few newer ones, it may be worth trying some of these newer drugs, even though counterintuitively we think they may cause lupus, they may actually be helpful for certain aspects of lupus. And this just, again, tells you what happens with the joint pains with lupus, and the tender and swollen joint counts go down, and then they go back up when you stop the drug. So this is when the infusion was given here, no more infusions given, and you can see a fantastic effect, but then when you stop the drug, don't give any more infusion, everything goes back up. So definitely good indication that these drugs can be helpful in lupus. We don't use them widely. I've used it in 1 or 2 patients with quite resistant lupus or with overlap with rheumatoid arthritis, and found actually the lupus hasn't got worse. In fact, quite the opposite. It's actually got better. Now, this is a complicated drug, so I don't expect you to read all of this, but this is one of the newer drugs, belimumab. Has anybody heard of belimumab or Benlysta? Is anybody on it? So Benlysta. So, believe it or not, Benlysta is the first drug in 60 years to be licensed for lupus. Okay? Now you're all wondering, well, I'm using these drugs, are they not licensed? Actually, they're not. So mycophenolate is not licensed for lupus. Okay? Rituxan is not licensed for lupus. So are we doing anything illegal? No. We're trying to save patients' lives. Okay? So we have to use these drugs, even though they're unlicensed indications. They are licensed originally for other indications, so rituximab for cancer, as we've said, but we've just grafted them on to the area of lupus because we don't want to wait for licensing. We want to know if we can save patients' lives with these drugs. Now, belimumab, on the other hand, is actually licensed for lupus. So it was developed specifically for lupus, and it's the first drug in 60 years that's licensed for lupus. So it's a long time. It just shows you how complex the area of lupus is. And really what this is alluding to is the normal. So you get normal levels of this chemical called BLyS, B-L-Y-S. So it's called B lymphocyte stimulator, BLyS. And it basically stimulates these B cells again, and that way you get a normal immune response. When you've got untreated lupus, you've got much higher levels of BLyS, and that's what is thought to propagate the immune response. So it allows these B cells to just get out of control. And as a result, you then get an out of control immune condition called lupus. So it would make sense if you've got high levels of this BLyS to then target the BLyS with an antibody. And that's what Benlysta is. It's just an antibody which is given by infusion on a monthly basis. And it attaches onto BLyS in your system, and that BLyS attaches to the antibody and is removed, with the result that you get back to hopefully normal levels or reduced levels of BLyS and less of an immune response, and therefore the lupus gets better. And so that's the rationale for using belimumab. The good news is, sorry, go on.
So can the BLyS be measured?
Yes, it can.
So you can do a blood test for it?
We don't routinely run levels of BLyS, okay, in our routine NHS clinics. This is a research kind of tool.
Yeah.
What we know is if you measure BLyS in research studies in people who have active lupus, BLyS levels rise, and they're much higher than they should be.
Yeah.
And that reflects the fact that some of these cells, which the BLyS is then stimulating, then become overexcited and then start churning out antibodies, which then make the immune response on the lupus worse. Okay? So BLyS can be measured, we just don't measure in routine practice in NHS hospitals.
With this BLyS, is there any relationship between the BLyS and complement or with the other ones?
The relationship is a complicated one. Okay, so the short answer to that is yes, there probably is, simply because we know that belimumab seems to work best in those patients who have high levels of that specific lupus antibody called double-stranded DNA, which is measured in routine practice, and also in those patients who have low complement levels. So if you have high double-stranded DNA and low complement levels, belimumab seems to work better in you than in other patients. Okay? So there seems to be a relationship, definitely. I was just about to say good news, but I forgot what the good news is. But no, I haven't forgotten, actually, I've just remembered. So the good news is, do any of you know the funding body called NICE?
Yeah.
It's the National Institute of Clinical Health Excellence. So NICE is a body that oversees some of these newer treatments, and with all the evidence put together, then says, yes, as NHS physicians we can prescribe this drug, or no, this drug is not cost effective, the evidence doesn't suggest that it should be used. So Benlysta thankfully has been given approval by NICE, so it will be available well, it is already available for any of you patients with lupus who fulfill those criteria. You've got to have active lupus that's been resistant to treatment with drugs like mycophenolate and azathioprine, and who have high double-stranded DNA levels and low complement levels in your bloodstream. Double-stranded DNA and complement are two blood tests which you may or may not be aware of, but they are used by lupus physicians to monitor the lupus.
Can you say that again, please?
So double-stranded DNA and complement. And complement isn't, wow, you look great, it's C-O-M-P-L-E-M-E-N-T. So complement. So those are the criteria for getting this drug, and because it's approved by NICE, it can actually again be used in the same way as the Rituximab. You were asking, will your local hospital be able to provide it? What NICE has said is, again, it should be prescribed with the collusion, if you like, or collaboration of a specialist centre. So again, your local physician, if they feel you would benefit from Benlysta, will then collaborate with the local specialist centre, and then the drug will be given. That's it. So NICE will be happy then to pay for it. So this is all good news. Rituximab has been approved by NHS England as a funding body. Belimumab has been approved by NICE as a funding body, and they're drugs which you can have, newer drugs which you can have, if you fulfil the criteria, of course. That's fairly important, but you know, these just allow us a little bit of breathing space to think, if somebody's got really, really aggressive, difficult to treat lupus, we can then now, as with rheumatoid arthritis, start relaxing and saying, yes, well, if it doesn't work, we'll try drug X. If that doesn't work, we'll try drug Y. We've got that option now in lupus, and slowly but surely you can see the number of medications that we can use, the newer ones being much more targeted than more blunderbussy older medications, and there's, you know, quite a lot of hope really for the future really with lupus, thankfully. So Benlysta is available, and sorry, there's a lot of graphs here, but essentially these are some of the studies that will have been done, again on a global scale. So these aren't just looking in London or Newcastle or wherever. These are global studies looking in the States, throughout the whole of Europe, the Far East. So these are hundreds of patients. And basically, this probably hasn't projected very well onto here, but all of these, this one here, I'm trying to think actually if I can actually read any of this, probably can't. But if you just look at I think the grey line here is the placebo, and the purple line is belimumab or Benlysta, and you can see there's a gap between the two. And these are the percentage of people that respond to the drug. Now, you can see even with placebo, you get a good response. Placebo response is really quite strong. So in many, many studies. Okay. That's the case in many studies. But there's also a reason for that, and that's also because in the placebo group, again, you're allowed for flare-ups to use things like steroids. And so you're going to see less of a difference than you might do otherwise. So you can see from that, the responder rate is much higher. You've got multiple, I can't even read them. Let's just see if we can actually get them. But there's several measures, and some of these are, let's just see. Oh, I'm going to have to sort of maybe present this again with individual slides, but there's several measures of disease activity which include things like double-stranded DNA measures, joint pain, fatigue, tiredness. All of these measures have been utilised, and all have been found to be better in the belimumab group compared to the placebo group. And I think that's the take-home message. One of the nice things about belimumab, I'll come to in a second, but who in this room with lupus has fatigue? So the majority of you. One of the nice things, this is another graph, a little bit easier to read, but again, this is belimumab with placebo, Again, if you look at the placebo here compared to the belimumab, you can see there's a big difference between the placebo and belimumab groups in disease activity, which drops in both groups, but much more so in the belimumab group. One of the benefits of belimumab that we're finding is an improvement in fatigue. And certainly in the States, where it's very easy to prescribe some of these drugs, and physicians will often prescribe them probably earlier than here because they've got license to do it in the States. They've found that in real-world practice, fatigue actually reduces with belimumab. It's one of the drugs that seems to be quite important in that. So if you do get put on belimumab because you've got lupus which is quite aggressive and resistant, you may find that the belimumab actually helps reduce your fatigue, which I know is one of the biggest bugbears for you as patients, but also for us as physicians to try and address. And in fact, there's a Lupus UK article which I've written, which hopefully will give you a broad scope of things to do about fatigue and what works and what doesn't work. I think that's going to be published hopefully in the winter edition.
Yeah.